I would like to welcome you here in this scientific event where we are all together here to share experience and to exchange knowledge about a very important topic, which is herpes zoster. I'm very glad to have another group of our healthcare professionals who are a very solid and very important member of our medical team. Who are you? Nurses, the angels of mercy. So I would like to welcome you all here for this wonderful gathering, and I hope this will add a lot of opportunity for you to know more about the disease and to identify your role as a nurses in combating the epidemicity of this kind of disease and to relieve the suffer of all the patients who might get the disease because of our reluctancy to be proactive, to work hard for the best interest of our patients. So as you know, you are a very important member, and you are the first contact with patients, in fact, if you are sitting in the outpatient department. So during your triage, which is a very golden opportunity to come encounter with patient while taking the vital signs, you have to identify those patients at risk of getting the disease of herpes zoster. And once you initiate the questions, did you take the vaccine, this will change the patient's perception from pre-contemplation to contemplation state, and then he will be active and proactive to understand the importance of these vaccines to safeguard his health. So this is your important role. So your contact with patients comes as the top priority to put you in the leader to tackle the problems at all the levels of the communities. And if you are working in an inpatient department, you have a lot of time to spend with your patients. You establish your own way of having a good nurses-patient relationship. And with this kind of trust, definitely if you deliver an advice which is committed to the quality of statement of art, of information, definitely it will be perceived very well by your patients. So with this, I just would like to have this kind of introductory statement to let you know how important you are for us while we are planning, to make some additional movement out of the box to tackle the disease. And today we are going to have these sessions, which is dedicated for you. And I'm very privileged to have two of my eminent, prominent speakers, infectious disease and epidemiology. I have Dr. Raja al-Radadi and Dr. Tarat al-Misani, and I would like, on your behalf, to thank them very much, for contributing and dedicating their precious time to come all the way and to exchange their expertise to let us know more about the disease and to identify our role. I would like to thank also the Saudi Society for Family and Community Medicine, because this session is under their partnership, and IMC, International Medical Center as well. Special thanks goes to GSK for sponsoring this event, and I would like to also extend my thanks to the Fexus company, the organizers. So I wish you a very fruitful sessions, and be courage enough to ask questions and to learn more, because this is your opportunity, which you always miss it once we leave our schools of medicine. So we'll have no one to teach us but this kind of events. So with this, ladies and gentlemen, I would like to introduce my first colleague, Dr. Tarat al-Misani. He's a consultant family medicine and geriatric, assistant professor of family medicine and geriatric, and he has American Board Fellowship in Geriatric from Oklahoma University, American Board of Family Medicine, Texas University, and he has a clinical research fellowship, George Washington University. And I'm very sure that he has a lot of contributions, for the educations of physicians and the other members of the team, and he has a lot of research and activities. So on your behalf, I would like to thank him for being with us here today. Thank you, Dr. Tarat. Okay. So you can use this, or you can use this as well. And you have the screen over there. Okay. Sure.
شغال كويس اوكي طيب شكرا بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء المرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good evening everyone. Thank you all for being here tonight. and giving us some of your precious time to join us. My name is Tarat Al-Misani. I'm a family medicine and geriatric consultant, and I work as an assistant professor of family medicine and geriatric at Al-Bahia University Medical School. Thank you, Dr. Rasha, for your introduction. And I'd like to thank the organizing committee for inviting me. Okay, so tonight I'm going to be talking about shingles or herpes zoster, some basic informations. Before I start, I usually take this opportunity to talk a little bit about geriatric medicine since it's a new specialty. And when we define geriatrics, it is the medical specialty that try to diagnose, treat, and prevent diseases for the older adults. And when we say older adults, we don't actually have a cutoff number for the age. It is different from one country to another. In Saudi Arabia, we consider people to be joining geriatric population when they're 60. But it's different in the United States, where 65 and above are considered geriatric patients. But why do we have geriatric medicine? As we have pediatrics, we have geriatrics. We have pediatrics because children and adults, they have a different set of physiology in their body, and that's also what we have for the older adults. As we get older, our physiological capacity get smaller and deteriorate gradually, which is fine. No, nothing wrong with that. But with that comes a lot of changes. Our body systems, either the central nervous system, the cardiovascular, the respiratory, or any system in our body change. The functions decreases progressively and slowly with time. And one of these changes also happens with the immune system. What happens with the immune system as we get older and older is that the adaptive or the innate immune system, part of the immune system, or the humoral or the cellular part of the immune system, become less active. We have less number of T cells, B cells. We don't act against harmful germs or infection the same way. And that's actually what happens, and it's very relevant to our talk tonight. There is something called immunosenescence. Probably a new term, but immunosenescence means it's the natural progressive decline in immune system function as we get older. And it seems to be this factor of progressing slow decline of the immune system function cause the herpes zoster. But we're going to dive into that in a few minutes. Before I proceed into more details about the disease itself, the signs and symptoms, how we usually treat these conditions, and we talk about the complications, we're going to talk a little bit about some epidemiological data. In 2014, an article was published at the BMG. It was entitled Systematic Review of Incidence and Complications of Herpes Zoster Towards Global Perspective. The research group allocated 130 study that was published up to the December of 2013 from 26 countries, and they looked into the data from these several published research. What they found is that as we get older and we hit the age 50, the incidence of herpes zoster increases for some reason. That happens coincidentally with the natural decrease of our immune system function, or what we call again immunosenescence. But it seems that as we advance in age from one decade to the next one, the incidence or the chance of having herpes zoster increase with time until we reach the 70s or the 80s. We reach a point where from every 3 older adults, they have a 30% chance of having herpes zoster. So 1 out of 3. Another observation that they saw from these systematic review findings is that the chance of developing what we call post post-herpetic neuralgia, which is the most common and feared complication from herpes zoster. It increases with age. This means that if you are 60 or above, between 60 and 70 years old, from the percentage of contracting or developing post-herpetic neuralgia as a complication is 10%. But if you are 70 or more, the proportion doubles along with that. This means the chance of developing post-herpetic neuralgia will become more and more. The problem with this is that the world is aging, and as the medicine is advancing, we tend to live longer. So the chance of living longer, developing the herpes zoster, and so the post-herpetic neuralgia will become more and more. One more thing is that as we get older, of course, for a newborn, their past medical history obviously is 0, but as we get older, we tend to attract more and more diagnoses from chronic diseases or something else, diabetes, hypertension, dyslipidemia, or cardiovascular disease. So as we get older, we accumulate more and more diagnoses, and the problem is as we enlist more and more diagnoses to our personal past medical history, that will affect our immune system in a negative way. It will weaken our immune system more, and so we will have the tendency of exhibiting and reactivating the virus causing the herpes zoster. Okay. As you can all see from the flyers presented in your table, that 99.5% of all of us, 50 and above, we have the virus causing the herpes zoster inside our body already. How come? How come? Okay, the story starts from the childhood. If you contracted chickenpox during your childhood, you have the virus that it's causing herpes zoster already inside your body in a dormant way. It is sleeping. Okay? So, we contract the virus initially during the childhood through what we call the chickenpox, called in Saudi called angaz. Okay? The causing virus is the varicella zoster virus. This is the causing virus for the chickenpox. It is the same virus that is causing the herpes zoster or the shingles. So we contract the airborne virus during the childhood for the chickenpox, the VZV infection, and of course it is manifested as a skin rash, as a vesicular way, dries out. Then the same virus that comes through the airborne transmission, go through the lymph nodes in our throat, then through the bloodstream. It manifested itself as a rash over the skin. And as we heal from that virus, it goes inside the nerves ending, the sensory nerve endings, toward the center of basal ganglia around the spinal cord. And it stays there for many, many years and decades. What is interesting about this virus is that it down-regulates the immune system. This means it manipulates the immune system for multiple decades to become undetected until we hit 50. And our immune system gets weaker and weaker. And if you, God forbid, get exposed to a type of trauma, emotional trauma, physical trauma, surgery, anything like that, the virus wakes up. And that's when it wakes up from that dorsal root ganglia, and it starts to multiply inside these sensory nerve roots until it reaches the skin to become manifested as the typical skin rash that comes in one side of the body. Okay, herpes zoster rash usually follows a unilateral distribution, erupting in 1 to 3 adjacent dermatomes. What does that mean? In 2007, there was an article that was published in the American Academy of Dermatology that wanted to look where are the most common dermatomal distribution for the herpes zoster rash to appear. And they found that the thoracic distribution, which means the chest and the abdomen, are 56% area of distribution most of the time. Where the lumbar is 13%, the sacral one is 4%, and when it happens to the sacral part, sacrosensory dermatomes, it can extend to the limbs, the upper or the lower limbs. The cranial, which means the face, cranial nerves, and finally the cervical. Of course, each one of those lines that you can see over here, it's a specific dermatomal area of covering that by that sensory nerve. One of these sensory nerves, when the immune system is weakened, the virus will wake up and it will follow that track. It could be 1 or 2 or 3 dermatomal distribution. And this are the specific areas where the patient will start experiencing the rash, and before that, the severe pain. The problem with this is it's very difficult sometimes to diagnose herpes zoster honestly. The reason is, if the dermatomal distribution, for example, started in the left side, okay, and it went around, let's say, T4 or 5, thoracic pathway. In the left side, we have the heart over there. And if a patient came to the clinic or a hospital complaining from a chest pain, probably we wouldn't know from the beginning that this is because of herpes zoster. Usually patients start experiencing something funny, some sort of a pain or some sort of an itching going on before the rash start. So of course we will think firstly that we need to rule out any cardiac cause, a life-threatening reason to think about. Another factor that it's actually pretty challenging is that in order to treat herpes zoster very well, we have a window of opportunity to diagnose the patient in a right way and to start the medication, which is an antiviral, acyclovir or valcyclovir. We have a 72 hours window of opportunity to diagnose and treat the patient. And this is actually pretty challenging too, okay? Okay, let's say that we were able to succeed in diagnosing the patient the right way and giving the right prescription of an antiviral treatment, and the patient was compliant. The regimen for this antiviral, it's different from one company to another, but it is difficult. Sometimes you need to take the medicine 5 times a day. It is difficult. And there is still a chance that patients may develop this severe pain, or what we call the post-herpetic neuralgia. We're going to talk about it. But treating this pain is very difficult. This kind of pain, which is neuropathic, paracetamol or the visceral kind of pain or musculoskeletal pain medications doesn't usually work with that kind of pain. We need something that addresses the nerve pain specifically. And this is the challenging part. In order to prescribe such a medicine, it's becoming very hard to do that in Saudi Arabia. Why? Usually the medication that we tend to prescribe to control such a pain are antiepileptics like Lyrica, pregabalin, and gabapentin. And it's a controlled prescription medication. Other way to address this neuropathic pain is by giving antidepressants like amitriptyline, which is a big no medicine for older adults because it's severe anticholinergic side effect and the lot of trouble that it's causing. We can also use something called duloxetine, but it's not as effective as amitriptyline. So treating and controlling such a pain is very difficult for those patients. Okay, so what are the expected complications? Already spoke about one of them, which is the post-herpetic neuralgia. Post-herpetic neuralgia is a severe, intense pain that happens as a result of the dermatome sensory nerve destruction happened by the virus. For 30% of the people who get the herpes zoster, they may develop this syndrome of post-herpetic neuralgia. And 30% of those 30%, they may experience this pain for at least 1 year. Again, it's very difficult to treat. It can stay there for many years too. The number 2 most common complication involves the ophthalmic part of the face. Here, if the herpes zoster get affecting the cranial nerve number 2 or 3, or the trigeminal nerve, the ophthalmic part of the ophthalmic branch, it will cause a lot of eye problems: keratitis, scleritis, uveitis, and the acute retinal necrosis. The chance of developing that complication is between 10 and 15%. After that comes the cerebrovascular and the cardiovascular complications, where patients may develop cardiac events or mostly CVAs and strokes. And finally, the neurological complication, where it happens to less than 1% of the patients. Those patients may experience encephalitis or meningitis too. For a very small number of patients, they may experience death too with such a disease. Okay, so as you all seen from the flyers on your table, 99.5% of people who are 50 and above are infected with the virus that causes the shingles or the herpes zoster. Again, we contracted that virus during our childhood. 1 out of 3 people, the dermatome virus reactivate and causes the shingles, a blistering rash that can be excruciating pain. Shingles is a painful disease that can have a serious and long-lasting complications. You can see the picture on the left, the post-herpetic neuralgia manifestation, and in the right you can see the herpes zoster affecting the eye of the ophthalmicus. Okay, how do patients usually describe the pain? A group from the University of McGill, they prepared something called McGill Pain Questionnaire, and they assessed the sensory words that used by patients to describe this kind of pain. 76% of the patients, they describe the pain as hot, burning, scalding, searing pain, where 60% described it as tingling, itching, smarting, and stinging pain. 59% boring, drilling, stabbing, and there was also a group of patients who would describe it like a thunder or electricity going through their skin. 51% pulsing, throbbing, beating, jumping, flashing, and shooting pain. The problem with such a pain is that it can affect the quality of life, especially for the older adults. Older adults are very sensitive and vulnerable to pain. Any amount of pain, even if it's mild, can really distort the cerebrum function for the older adults. It can cause delirium, and I'm sure that you're all familiar with that as you spend a lot of time with the patients. It will make them agitated, confused, especially if they're like in a different environment like a hospital, or they have other active, acute, on top of chronic conditions going on because of that, triggering factor causing this virus to start acting again. Okay, in 2022, this June, Dr. Abdullah Khanizan, he presented a paper about the public health impact of introducing an adjuvant recombinant zoster vaccine in the Kingdom of Saudi Arabia. It was presented in the Virology World Conference, where it was proposed that since there is 30% of people without vaccination will develop herpes zoster during their lifetime, there is a necessity for an adjuvant recombinant zoster vaccine to be introduced and given to people who are 50 years and above. The objective of that talk title was to estimate the public health impact of introducing the RZV, or the recombinant zoster vaccine, versus no vaccination for people who are 50 years and older in the Kingdom of Saudi Arabia, using what we call the ZONA, or the Zoster Economic Analysis Model. The conclusion was that the estimated number of people required to be vaccinated to prevent one case of herpes zoster was 8 people. So you need to vaccinate 8 people. This is something we call the number needed to treat, and to have such a number like 8, it's considered low and it's pretty significant, so it's very helpful. Well, the number of patients that we need to vaccinate to prevent a single case of post-herpetic neuralgia is 46, and it's a pretty good number too. Okay, the number of people who are 50 and above in Saudi Arabia are around 3 million. Okay, so they were proposing that vaccinating of 3,539,362 people in Saudi Arabia with the vaccine, newly offered vaccine, would avoid 474,322 herpes zoster cases. And it also will prevent 73,046 cases of post-herpetic neuralgia as a complication. And that will prevent and save us around 628,680 healthcare professional consultation or visit, which is pretty significant. So in summary, older adults, and because of their physiological changes, they get immunosenescence process, and because of the chronic diseases that they suffer from, they get immunocompromised, make them vulnerable to reactivation, for the reactivation of the varicella zoster virus, and so developing herpes zoster. Herpes zoster can cause an intense pain, which is debilitating, and it will affect the quality of life for the older adults. Patients may develop serious complications. Herpes zoster symptoms have a major long-term impact on the quality of life. For any older adults, we want 2 things as geriatricians. We want them to be independent on themselves as long as possible and to enjoy their life. And finally, patients are often dissatisfied with the treatment of antiviral since it has limited efficacy in preventing the most rare complication of post-herpetic neuralgia. I won't go through the numbers again since I already presented that in a previous slide. Thank you all very much. Thank you all for your attentiveness and patience. And we'll take questions at the end. Thank you.
Thank you so much, Dr. Tarad, for this wonderful presentation. And you said it very elegantly, Dr. Tarad, the pathophysiology, the epidemiology, and then we landed up with the complications of herpes zoster. So I think it was so clear. So in order to be on time, I would like to introduce my colleague, the second speaker, Dr. Raja Raddadi. She is Associate Professor and Consultant of Preventive Medicine. She's a member of the Scientific Council of Saudi Fellowship, Chairman of the Scientific Board of Preventive Medicine in the Saudi Society for Family and the Saudi Commission for Health Specialties. Dr. Raja Raddadi, she's going to talk about the adult vaccinations practice. So this is a very practical point for you to understand exactly and to master all the information that will be said elegantly by Dr. Raja. Dr. Raja, thank you so much, and I would like to leave the floor for you.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. During the next few minutes I will talk about adult immunization practice. I will start with the age and the effect of aging on the immunity. I think Dr. Trad mentioned before about immunosenescence and the important factors that affect the immunity in the adulthood, including epigenetic changes and also chronic low-grade inflammation that reduce the immunity, and immune exhaustion or impaired immune competence for the older population. Also, immunosenescence, when we talk about the adult immunity, we can see a lot of factors and very highly prevalent in our community that lead to reduce our immunity when we go with the age, including sleep deprivation, gut probiotics, obesity, stress, and all of these factors that we can notice it in our lifestyle will lead to impaired in the immune system, immune cell function, reduced vaccine efficacy, and finally low-grade chronic inflammation that can reduce the immune system and make us more prone to develop infectious disease. So the effect of aging on infectious disease, as we can see here, that the influenza attack and mortality rate between 2000 to 2004, although we didn't have the age of this population, but we can see there down, we go with the age, the mortality increase with the age, dramatic increase in the mortality when we go advanced with the age. The second one, we can see in the second one here that invasive pneumococcal disease in 2018 published in the Europe. You can see here that the highest increase in the cases is with advance in age, and also the incidence of herpes zoster by age from 1992 to 2010 increased sharply with age. The impact of immunization program, we usually see that. Okay. The impact of vaccination program, as we can see here, there is reduction in the invasive pneumococcal disease in children by 77%, and reduction in the invasive pneumococcal disease in children before 7 years in Netherlands by 29% up to 50% in the New Zealand. So immunization is a cost-effective and critical element of preventive care around the world. This is an example of the vaccination recommendation in adult more than 50. If we can see Saudi Arabia, the recommendation of the most common, as we mentioned before, a lot of vaccine are recommended in Saudi Arabia, but we're presenting here fourth vaccine. In Saudi Arabia, seasonal influenza recommended yearly, pneumococcal disease recommended for the age more than 65, and shingles for age 50 years and above. Okay. This is the national immunization schedule for adults. As we can see, a lot of vaccine, including influenza, MMR, varicella, HPV, pneumococcal vaccine, hepatitis B. All of these vaccine, we need to introduce it for adults. What we can do for all of these, for 11 vaccines. So we will talk about vaccine acceptance of our community to start changing the perception of the community about the vaccine. This is an example of rare and very rare adverse event following immunization that the population see. They forget the effect of the vaccine, only they remember that there is anaphylactic case. However, we can see here, anaphylaxis is 0.2 to 10 cases per 1 manual dose. OPV also paralysis, 1 case per per 2.7 million knows mumps the same, and measles, mumps, rubella. There is reported cases of idiopathic thrombocytopenia, 1 case per 40,000 cases. So when they read about this or hear about one case, they concentrate on this, they forget the effect of immunization. Why? And we can see here the outweigh of evidence of vaccination benefit compared to the risk of or adverse event. When we want to discuss that, why that happened? Because the outcome is negative. For example, the disease is reduced or eliminated by the use of vaccine. For example, at one time, 175,000 cases of diphtheria were reported annually in USA. However, in 2002, only 1 case was reported. They forget the disease, they only remember the vaccine and what happened from the vaccine. That's why when we talk about the vaccine, it's very difficult to convince the people. So the acceptance of the vaccine measured by vaccine hesitancy scale, ranging from when the patients say, I am suspicious of vaccine, to I think vaccine are a great idea, and all the population between this scale. Public perception is not always positive, and decision-making around vaccination entails a complex mix of cultural, psychosocial, social, political, and cognitive factors that determine the decision of the patient to take vaccine. So vaccine decision-making, we have anti-vaccinism, and this is a very big problem. We talk about that, but now maybe after COVID-19, we can notice that it's improved. This refers to the total opposition to vaccination. In more recent years, anti-vaccinations have been known as anti-vax. The most important modifiable one is vaccine hesitancy. We define that the term covers outright refusal to vaccinate, delayed vaccine, accepting the vaccine but remaining uncertain about their use, or use certain vaccine but not other. This is an important factor in our community that we should acknowledge and work on it to improve the acceptance of the vaccine. So the vaccine hesitancy, either due to lack of confidence or ineffectiveness of the vaccine. They think that the vaccine is not safe, ineffective, or the system may play a role. There is no implementation of the vaccine, no dissemination of the strategy, no training of the healthcare workers, and there is sometimes this is the cause. And the second one is when I perceive that I'm not at risk, the risk perception for the population. I don't think that I'm at risk that need to take a vaccine preventable disease. And finally, lack of convenience in the availability. I think when I go to the primary healthcare center, I will not find the vaccine. I don't know where I can find the all of these are system related. So when we want to improve the vaccine hesitancy in our community, we should work in the full range from the policy, community, institutions. How can healthcare professionals communicate effectively with the public about vaccine? We will talk in detail about the education about the vaccine, but how we can provide this education for the patient. There is a courses and sometimes diplomas talking about vaccine, or how we can make the population look to the vaccine in a positive way. We should gain their trust, provide reliable information. Don't talk about study with the patient, talk about experience. Use patient-friendly language and reinforce understanding of the benefit-risk of the vaccine with the patient. This is actually the role of all healthcare professionals to do that with our patient to reach to a high coverage rate of the vaccine. This is some studies about vaccine hesitancy in Saudi Arabia. This study published before COVID-19, published in May 2019, talking about investigating factors associated with vaccine hesitancy in Mecca. And they found that the vaccine hesitancy is 31.3%. The second study also published, I think this one in 2016, talking about the prevalence of influenza vaccine hesitancy at tertiary care hospital in Riyadh, Saudi Arabia, is 17%. I think patients who attend tertiary center, they are more willing to take vaccine because either they are tired or they have recommendation to prevent secondary infection, and maybe this will underestimate the hesitancy scale, or we couldn't generalize this study in the general community because it's conducted in a tertiary center that only reflected or generalized on the patient who are attending a tertiary center. There is a study about the hesitancy scale of COVID-19 vaccine comparing Arab countries and non-Arab countries. A high rate of COVID-19 vaccine hesitancy in a large-scale survey on Arab found that 83% in the Arab countries have hesitancy about COVID-19 vaccine compared to 81% in other. But this one was at the beginning of the COVID-19. There is another study, unpublished study, we conducted it in Kingdom of Saudi Arabia by students from King Abdulaziz University, looking for vaccine hesitancy in Saudi Arabia. We found that vaccine hesitancy 31%. We asked the people if it's not mandatory, you will accept or you will go to take the vaccine. 31% they said we will only take the vaccine because of it's mandatory and we couldn't go around if we didn't take the vaccine. If we know that generally in Kingdom of Saudi Arabia the coverage rate of COVID-19 is not more than 71% for at least one dose. That means for those who with 2 doses is less than 70% and 3 doses much less. When we see after all this tawakkalna and all what happened in the community regarding enhance the population or motivate them to take the vaccine, still there is 30% of the population unwilling to take this vaccine. Now we will talk about vaccine confidence, how we can reach to the vaccine confidence and believe that we need our community to believe that the vaccine works, safe, and are part of the trustworthy medical system. If we reach to this in our community, we can improve the adherence to the recommendation and improve the coverage of the population regarding the vaccine-preventable diseases. In conclusion, as we mentioned in the previous session and this session, immunosenescence is a key feature of aging that reduces resistance to infection. Implementation of national recommendation is crucial even during COVID-19 pandemic, and recommendation should consider not just age but also risk group who in need for certain vaccination. Public health impact model are tools that can help assess and access to the best vaccination option in our country. Thank you very much.
Thank you so much, Dr. Raja, for this informative, illustrated presentations. And I would like now to move to our speaker, Dr. Mansour Khalaf. Dr. Mansour Khalaf, he's a registered pharmacist with a master's degree in public health from Denmark, and he has a diploma in infectious control from the United States, member of the Canadian Public Health Associations, have 5 publications in the field of epidemiology and pharmacoeconomics, and he has a lot of publications and contribution to many research that has been conducted locally and regionally in the field of vaccines. So Dr. Mansour, he's going to shed light on the most important part of our gathering today is the Shingrix vaccine, and he's going to highlight all the details, practical points of administrations and even preservations of the vaccine. So I think this is quite practical sessions. So I would like to thank Dr. Mansour, and I will leave the floor for you.
Assalamu alaikum, and good evening, everybody. Thank you much, really, for keeping me for the last session. Actually, the sweet comes after all. So I'm considering my presentation now will be things that you will be really enjoying. Well, let's first, before I go into this discussion, I want to ask one simple question. How many of the attendees, they haven't catch chickenpox during their childhood? They haven't catch chickenpox during their childhood? No? 0. Oh, that's amazing. So everybody have experienced chickenpox during childhood. Correct? Okay, so that's good, cool. So everybody is susceptible for herpes zoster. Okay, well, let's move. Okay, So this is a disclaimer. I'm fully paid GSK Medical Affairs employee, and we'll talk about Shingrix. Okay, well, let me give you one important thing, that not all vaccines are the same. So this is one of the vaccines that is made with the genetic engineering. So it's called recombinant. So it's not live attenuated, it is not kill inactivated, it is a genetic engineering one. So they call it recombinant. So recombinant is made through somehow genetic engineering stuff. In Shingrix in particular, they found that there is, in the envelope, outer envelope of the virus, there are so many antigens, okay? So many antigens, but one of those most available antigen called glycoprotein E. So how they made this glycoprotein E? They actually made it using this tiny creature here, which is called the Chinese hamster ovary cells. So they are using the ovary cells of this tiny creature here, or the Chinese hamster, to produce the vaccine. So produce the antigen, I mean, which is called the glycoprotein E. This is, of course, it's very important. Why? Because glycoprotein selected based on its role in viral replication, number one, and cell transfer that promotes viral spread and the pathogenesis of skin lesions. So it has very important role amongst other antigens that is available in order to make sure that this vaccine is effective. Number two, it's very important that I want to ask another question here. What exactly is the most important once we are given a vaccine? Is it the efficacy, number one, or safety? Which is number one? Efficacy? Who's saying efficacy number one or safety? Which one is for vaccine is number one? How many said safety? Oh, how many said efficacy? Number one. Oh, nothing. Well, that's good, cool. So safety, yes, exactly. While in medication, it is efficacy. So this is the difference. Safety, because he's sick, he or she, they are sick, so they are really seeking actually the safety. So in order to make sure that this is really very safe, we tend actually to select, very importantly, the antigen, and to avoid the side effects that are caused by the virus itself or the pathogen itself, which is the natural one. For example, in herpes zoster, as Dr. Tara, he mentioned, there is a lot of side effects comes once the patient being infected with a herpes zoster. So in order to avoid all of this, we add something called adjuvant. So the adjuvant is a supporter to the antigen called the glycoprotein E in order to ensure that it has the highest efficacy with the lowest side effects compared to the natural virus itself. Okay, so here the adjuvant system called AS01B. So AS01B, it is the adjuvant that has been used in this particular vaccine in order to ensure efficacy with the lower with the high safety, high efficacy and high safety. And I will show you later on what I mean by this one. So it's two components. You will see it in a vial, in two different vials. One of them is called the adjuvant, which is a liquid, comes in liquid, which I will show it later on, and the antigen, which comes as a lyophilized or as a powder. Okay, well, this is the things that I want to show it here. As you can see in the axis, it's immunogenicity. The native pathogen is very high in terms of immunogenicity, but however, intolerability is very low. So this means side effects is high, which is disease. However, when you go down until we reach the purified antigen, which is called recombinant, that I have just mentioned right now, recombinant one, you will find that the tolerability is very high, however, efficacy is low. So what we tend to do here, we tend to do adding the adjuvant in order to increase the immunogenicity similar to the native and reduce, of course, maintain the low side effect. So this is how we made it, and this is why this vaccine is considered to be really safe. Okay, so there are different, as I said, different type of adjuvant. So this is kind of different, and I don't want to make it really complicated, but however, different vaccine, sometimes you find that they have different type of adjuvant that is being added. For example, hepatitis B that's used for hemodialysis. HPV vaccine currently is, I don't know if you have seen it, HPV for cervical cancer. It has an adjuvant called S04, and Zoster, of course, S01, and so on. Okay, so this is again another thing that I might really skip this one because I have just mentioned everything related to this presentation. Okay, well, now we'll go to safety. I know that you are looking for safety, but let's go, before we go to safety, let's show you some efficacy of this product in particular in those 50 plus population. So there was 2 studies. One of them, it was a larger scale study, and it was multi-center, multi-country, and actually multi-content, to be honest. The first one was used in individuals 50 plus years old. The second one was used in individuals 70 years plus. So in the first one, the number of individuals was used on them was more than 16,000, and in second one, 70 plus, was around 15,000. Where it has been actually tested, it was tested in North America, in Europe, Latin America, Asia Pacific. So I said multi-content. And what was the study designed? It was randomized, observed, blind, placebo-controlled, multi-center. Okay, and what was really the objective behind the study was to measure 2 things. Number 1, the efficacy. Number 2 is the efficacy against both herpetic neurogenic 70 plus and herpes zoster efficacy, as well as in those patients. What was the result? And this is very important. In all age groups, whether they are 50 plus, 50 to 60, 60 to 70, more than 70, it was not less than 96.6% efficacy. I mean that preventing the herpes zoster. While in the pool study, which is between 50 and 70, both studies, it shows that above 70 years old was more than 91% efficacy. And this is really great, to be honest, with those age group that they have lower immunity, it shows a very high efficacy. Okay, well, let's go to a very important thing, which is Dr. Tarada during his visit, he mentioned it, which is the post-herpetic neuralgia, which is very painful kind of complication related to the herpes zoster. It's called post-herpetic neuralgia. And in post-herpetic neuralgia, the vaccine efficacy against post-herpetic neuralgia was showing actually a very high percentage in 50 plus and 70 plus, reaching 91 and 88% respectively in both groups. Okay. Very important. How long this vaccine will be effective? Shall we use it multiple doses and repeat this dose after 2, 3 years or 4 years after the course? Well, in this study, it has shown that above 50 years old, whom they have used the vaccine, a continuous actually efficacy reaching up to 10 years until now. And this is very important. So whenever that vaccinee, by the way, they are not patient, so we should not call them patient. They are a vaccinee or eligible for vaccines because they are healthy individuals. So whenever that they will ask, okay, how long I should stay before I took the second shot or the booster dose? Until now, after 2 shots of this vaccine, reaching almost 10 years of efficacy. So we don't need actually to repeat the dose every 2 years or every year, like for example, the flu vaccination. Okay. Now for the safety, which you have all agreed that this is the most important. For the safety, pain, redness, and swelling, which is in the injection site. As you know that vaccinees or even babies and adults, whenever they take a shot, usually they suffer from something like this. So this is solicited injection site reaction, and with a different age group, it reaches between up to 80% in those 50 plus. So 80%, but very important, that doesn't last more than 3 days. This is for pain. Redness reaching almost like 38. Again, for 30 days or less, and swelling is the same thing at around 26%. So in conclusion, it was tolerable to be honest. Yeah, tolerable, not more than 3 days, usually 1 day to 2 days. But however, this was really the most reported side effect. If we go to systematic, which is fatigue, fever, headache, myalgia, shivering. So again, with a different percentage or different age group, but again, very important, I want to mention something that doesn't last more than 2 days. Usually 2 days and then will disappear. So you may really need to advise this one. You might really suffer from something like pain on the injection site or redness or even fatigue, but this doesn't last more than 2 to 3 days. Okay? This is the serious adverse events. Like for example, serious adverse events or fatal adverse events. And this is compared to placebo, because in this study there was a placebo, so some patients or some vaccinees, they give them the vaccine, some others they didn't give them nothing, and it was really comparable, it was the same. So doesn't mean that it was from the vaccine. Usually we report this one, but however it was similar to placebo. There was no additional serious adverse events reported with a vaccine compared to placebo. Okay. How can we implement Shingrix or RSV in your practice? How many doses, first of all? It's 2 doses. So it's 2 doses. The first one should be given now. A second shot, you have a period of 2 to 6 months. So either you give it after 2 months, for example, if you give it January, beginning of January, you give it by March time. January, February, March. Or you can, a vaccinee can stay up to month of June. Usually, Ministry of Health nowadays, they recommend 2 months. Before they were recommending 6 months, and now they go into 2 months. So 2 months is much more actually closer due to the nature of the vaccines themselves, because they are, adult. So usually it's not like a pediatric. So this one is very important. Okay. Can we go for 1 dose only? No. There is no way that we can go for 1 dose. It hasn't been tested. And not only this, and what the study shows that after 2 doses, the efficacy or the immunogenicity reach 3-folds. So 3 times what we are aiming for. So it's very important to give 2 shots. There is no way to give it only 1 shot. It's very important. So please remind the vaccinee that you need to come back and take the second shot after 2 months or 6 months. Okay. So the vaccine actually came on 2 vials. Again, 2 vials. It's 2 doses, 2 vials. One of them is liquid, which is contained the adjuvant, as I said. So it's the helping agent. And the second one is lyophilized, which is the antigen itself, which is the glycoprotein E. So we have to mix them all together. Mixing is very simple. There is actually, we need to first of all to take the liquid out, add it to the powder, shake it, change the needle, and then administer it with a drone and administer it to the vaccinee. So this is the how we can really move it. A lot of questions came after reconstitution. How long the vaccine stay? Out? No way. We have to keep it in the fridge. So if the patient will say, okay, I want to go for Salah now, or I want to go for something else, or for any reason, we have only 6 hours. Even in the fridge, between 2 to 8, it's only 6 hours. Otherwise, we have to discard the vaccine. Okay? So it's only 6 hours after reconstitution, otherwise, and in the fridge, otherwise we have to discard the vaccine. Plus, very important, the bag or the box that contain the 2 vials, it shouldn't be kept in the freezer. It shouldn't be kept in the freezer. It should be between 2 to 8. Normal, as a normal other vaccines. I know that some vaccines, they can be kept in the freezer, like for example, polio, oral polio can be kept there. But this one, no. We should keep it only in the normal fridge between 2 to 8. How it is administered, it's intramuscular. No, we should give it subcutaneous, neither intradermal, and of course not intravenous. So it's only intramuscular. Okay? Well, very important. Let me go back here. Okay. can be Shingrix or this vaccine prevent chickenpox? Can be used to prevent chickenpox? If someone doesn't catch chickenpox during childhood, can be given? No. This is not indicated for chickenpox. This is only for herpes zoster. So it cannot be used for against chickenpox. It's very important. Okay. Could it be used with other vaccines concomitantly at the same session in different arms? Yes. Like, for example, influenza, seasonal flu vaccine, pneumococcal, which is a polysaccharide, and DTaP vaccine, diphtheria, tetanus, pertussis vaccine. So it can be concomitantly administered at the same time. Okay? Where it has been registered around the world in so many countries, North America, Latin America, in Europe, as well as in Saudi Arabia, and Australia, and in Asia. So it's available in so many parts around the world, and more than 50 million doses has been distributed so far from this vaccine. In summary, this vaccine is made from recombinant, so it's not live attenuated, it's not kill inactivated, so it is a different way that ensure safety as well as efficacy, high safety and efficacy. Number two, this vaccine is only for adults, 50 plus. Plus, we can use it in individuals 18 plus years old. From 18 years, if they are immunocompromised. For immunocompromised, yes, we can use it from 18 years old. So is this vaccine approved worldwide? Yes, approved worldwide, and it's being used. And there is, how many doses we should use it? It's only 2 doses. So 2 doses. We have to mix the 2 vials together before we give it to the vaccinee, and we keep it only after reconstitution for 6 hours in the fridge, between 2 to 8, and never been actually freezed. Okay, another question. After this, illustration, how many of you, if the vaccine is available outside this room, how many of you will take it? How many of you will take it? Okay, that's good, good. The rest, why? Why not? Because they are less than 50, yes, that's it. And this is now how you know it. It's not because there is a vaccine hesitancy, because it's it. Well, thank you very much, really. Appreciate your listening. Thank you very much. Yeah, thank you.
Okay, thank you so much, Dr. Mansour, for this informative presentation. And now I would like to invite all the guest speakers to come on the stage here so we can start the Q&A sessions. And we are going to receive questions from our virtually attending audience. We have more than 400. And I was told that we have to receive Arabic questions as well, and discussion should be somehow in Arabic as well as in English. So please, Dr. Tarad, Dr. Raja, Dr. Mansour. So to start with, we would like to open the floor now for the physically attending audience. Oh, we have many. Dr. Omar, تفضل.
السلام عليكم. أنا الدكتور عمر شمة, intensivist and pulmonologist. Thank you very much for the 3 nice presentations. I enjoyed the 3 of them. Shall I ask the question in Arabic, Dr. Ashraf, or?
Yeah, as you like, in English. Yeah, in English, go ahead.
I seem to be confused about the mechanism of action of the vaccine. Yeah, I know usually vaccines are to prevent new infection, and since the vast majority of the population by the age of 50 are infected with the varicella zoster virus. So how does the vaccine help in this case? I understand that the point is to prevent reactivation, but so does it prevent virus replication in the people who are already infected? Or what's the exact mechanism of action?
Thank you, Doctor, for your question. So let me just reiterate your question. So you're asking that since we have the virus in our body, how can the vaccine prevent the reactivation of the virus, correct?
Yes.
Okay, thank you. So we have the virus in our body. It's dormant. And it's, for some reason, with the interleukin, the interferons do the downregulation effect on the immune system. in all the decades up to 50 years old. When the immunosenescence, which is the natural loss of function of the immune system, happens, the number of the T cells, the effective T cells, and their ability to adapt in order to activate the B cells to give the antibodies is not as effective as before. For older adults, geriatric population, when they get sick, we don't actually see their immune system react in the same way as a younger adult, of course. Even in terms if they get stormed by a severe infection, maybe we don't see that is reflected in their WBC profile by increasing in number or even the neutrophils. What I usually see and what we know about the biology of and immunology in older adults, it really takes a very severe infection in order to either show a fever. That's why I take fever pretty seriously, and I see it in my patient population. But when I see, even if I don't see like a WBC leukocytosis in older adults, that not necessarily mean that there is no active serious infection process going on. The vaccine, what is just obviously, as we all know, like all vaccines, try to present that particle again. The adjuvant system, I think, is the initial part by increasing the immunogenicity of the antigen E part of the virus. I don't think if it's without the adjuvant system, it will be as effective. We have a previous vaccine that was started approved by the US FDA in 2004, Zoster. That was the life attenuated form. And when they did a comparison between the two vaccines, it wasn't as effective as the Shingrix, the one that have the adjuvant recombinant form. So I think the adjuvant is the main player here. The reintroduction of the virus particle, for somehow it's improving the T cell detection, and so the production of the antibodies by the B cells. Hope I answered your question.
Okay.
Very clear, thank you.
Yes.
Thank you.
Any questions from the audience here? Nurses? Anyone? Okay, I have a question here. For those who are immune-compromised patients with their low immune response, what will be, the outcome of giving them the vaccine and expecting to have a proper induction of the immune system to be protective fully for the Shingrix? Do we expect the same response and the same protections for the immune-compromised patients, or there should be some kind of adjustment of those also?
Okay, so someone who is immune-compromised and we're giving them the vaccine, do we see the same response as immunocompetent, right?
Yes.
So I'm not sure, but I think the Saudi FDA, they approved the vaccine for 50 years and above.
Yes.
The vaccine can also be given to a younger age group.
18 years.
18, if they are immune approved. 18 above who are immune compromised, either because they're receiving an immune modulating medication, immune compromising medications for organ transplant, or they have HIV or any other reason. Those patient population that they can benefit from the vaccine in the same way, but the way of administering the vaccine is instead of like 2 months apart between the first dose and the second dose, it is 1 month apart between the first dose and the second dose. They did multiple research regarding that to see is the immunogenicity or the immune system will react in the same way or not, and they found that the immune system the vaccine can prevent up to 60 or 70% of herpes zoster reactivation if they receive the vaccine. And usually the usual practice is to give the vaccine in ahead of a chemotherapy or an organ transplant by at least 2 weeks to give a chance to the body to develop antibodies against the virus. I hope I answered your question.
Yeah, thank you so much. Dr. Mohammed, تفضل.
Thank you very much. I think it's a broad discussion, but let me act like medical warriors regarding those, especially at this time of virus age, plus getting, with old age, geriatric part of it. Those, when we think about a reservoir in the body for those in the ganglia, so those viruses, I just would wonder, the herpes changing its character, or because we are administer some genetic engineering, element, is there any changing inside our body, because that reservoir will stay for years? So just wondering about this aspect.
Okay, do you want me to answer the question? Or I'm going to have the answer divided between me and Dr. Mansour Khaf. So yeah, the concern is whether or not, since we're injecting a genetically engineered particle inside our body, does that inoculate itself inside our DNA? Correct me if I'm right?
No, that's a part of it, but the other one, we are giving this immune agent as well. Mm-hmm. So the virus which hidden in our body,
yes,
not changing at all in its texture. That is and if that's changing, so how are we going to change as well our way to treat them?
So it is the varicella zoster virus itself, which is causing the chickenpox, then became dormant in our body. Is it genetical, the genetic structure of that virus get changed with time? So is it like evolving or changing like influenza, let's say? I'm not aware of, I'm not aware of anything that happens with that virus in particular like that. Chickenpox, of course, the herpes virus family is pretty big, but the herpes zoster, I don't think it's changing. If I'm mistaken. But this is one thing. The other thing, we are introducing a glycoprotein E, which is a pretty specific glycoprotein in the surface of the virus. And it's the one that we're targeting here, and it seems to be pretty effective in preventing that virus by making antibodies against that activation.
Well, thank you, my doctor. Actually, there is no serogroups of this virus. There is no serotypes of this virus, so it's only one. And it's not changing over time, as Dr. Terad just mentioned right now. There is no different, this is why I'm saying that it's not yearly. It shouldn't be given even yearly. And this is really faced, in fact, similar to the hepatitis B, for example, hepatitis A. So it is those kind of viruses that whenever that infect, so it created memory cells, and it lasts for long. So this is the situation with regards to the chickenpox virus or varicella zoster virus. And then whenever that we give actually the vaccine, which is RSV later on, which is this one, Shingrix. We target actually the memory cells at the beginning, as well as we target humoral and cellular antibodies in order to ensure that it will keep it in the dorsal ganglia. It's not doesn't cause reactivation. But to answer you, kindly answer you shortly, there is no different phases, so we don't need to change it, change the vaccine every now and then. No.
Okay. Dr. Raja, if you just can summarize the role of nurses in tackling the vaccine hesitancy.
السلام عليكم ورحمة الله. The role of nurse is very important in this era about the vaccine. They are now working on the vaccine for the pediatric. I think they have a lot of experience in that, how to convince the parent to give this vaccine to their child. Now when we talk about adult immunization, they need first to introduce the vaccine. They need to know how to communicate with the visitor to the health care facility, either primary care or secondary care. They should be aligned with the policy of their institution and what are the vaccines that presented, and their role depend on the adoption of their institution to the vaccine. If they want to implement all the adult vaccination schedule that's recommended by MOH, different from if they want to recommend one certain vaccine related to certain clinics. So if all nurses who are interested in working in the vaccination clinic, or if they have in their institute vaccination clinic, they should have a good training on adult immunization schedule, good training on a certain population, as we mentioned in the lecture, that we need to know the recommendation according to the age and according to the clinical situation. Secondly, for example, in our hospital, King Abdulaziz Hospital, we have a clinic. They receive also order from inpatient for the vaccination of high-risk group. The motivation of the nurse to introduce the vaccination, even if the patient or if the visitor they didn't ask, is one of the important role. But I think the policy and the institution should adopt that and help them and make sure that they have the vaccinated available in their institute. And I recommend that all institutions, they should have plan to start implementing adult immunization, and they should have the policy and distribute the roles, either the nurse, if she can prescribe it, or she can recommend it from the nursing office, or it should be referred from the hospital. I don't know what is, if you can share us your experience in your institution about adult immunization. Any of you have implemented adult immunization in their institution?
Yes. Yes, IMC was one of the organization that we started implementing the process of enhancing the adult vaccination since many years. And in fact, there was a lot of initiative that has been implemented successfully by the help of the nurses. For example, the smoking cessation, obesity, as well as diabetic peripheral neuropathy. So we have trained our nurses to ask the fifth questions after the vital signs. Are you a smoker, or are your body mass index is more than 30, or are you a patient with diabetes? So we initiate the process, and they tag our our HI system that this patient is a smoker or obese, or he has a diabetes. So they initiate the process of early identification of those patients, and we draw a clear pathway for them to take the patients through certain questionnaires, and then to deliver the patient to the concerned physicians to tackle the process. So what I expect today, after learning all of these things, your role will be to identify those patients at risk. And then your question should be, for those patients who are above 50 years of age, did you take the vaccine for herpes zoster? If no, this will alert the flag, and we might implement this in our new health system, and then you can initiate the process of getting the patient into the vaccination clinic to receive his vaccine. So I think this is the important role that we have to enhance and to capture those patients at risk, and this is not to be counted as a missed opportunity of getting those patients who are eligible to have the vaccine and leave the organization without having this valuable encounter with this valuable intervention. Do you have any other questions? Any other questions? With this, I would like to thank all of you for attending the session, and I would like on your behalf thank our guest speaker, Dr. Raja Raddadi, Dr. Tarad Tilmisani, Dr. Mansour Khalaf, and for the wonderful contribution for the success. And please remember that you play a very important role in combating the epidemicity of any disease, any infectious disease. So your role now, while you go and leave this hall, to practice the solid information that you have learned out of today's session, So try to identify those patients eligible to have the vaccine, initiate the process, try to be the pioneer to invent some inventions or interventions that can promote this kind of preventive services that we are very much responsible to adopt it successfully to safeguard our community and nation. I would like to extend my thanks to the Saudi Society for Family and Community Medicine. Special thanks for IMC as well, because this was partnership with IMC and the Saudi Society. A special thanks for JSK and for the organizations Fexus. So ladies and gentlemen, thank you very much for being with us here today. I wish you a very successful practice in managing our patients with herpes zoster. And we would like to have a group photos, and then we will go all of us for dinner. Thank you so much. Fi aman Allah.
Recording stopped.